I'm Dr. Scott Wright, Professor of Medicine and Cardiology at the Mayo Clinic and Associate Editor of the Mayo Clinic Proceedings. It is my absolute joy and privilege today to introduce Dr. David Holmes. Dr. Holmes is a Professor of Medicine and Cardiology, in fact, a distinguished professor. He's the former chair of our cath lab and Division of Interventional Cardiology, and has truly been one of the leading interventional cardiologists in the last 30 or 40 years. I always tell David that I came to Mayo Clinic because of him and his writings. And he thinks that's probably hyperbole, but it's not. I found a book of his in medical school and said I wanted to work with someone like him. So it's been my privilege to spend the last 30 years or so working in close proximity to David and learning from him. David, welcome to the interview.
It's nice to be here with you.
Thank you. David, you've had a remarkable career so far, and it's not anywhere near the end. If you look back over your time in interventional cardiology, what are the accomplishments that you have done that you feel are most significant?
I think that's terribly important. I think that the major accomplishment, maybe for all of us, is to identify and project an image. It's not a false image of what satisfying life professionally and personally should be. I think that's the image and the reality that we should project and live. I am reminded about the amazing sort of verse from Fulgham on everything I need to know I learned in kindergarten. That says, share everything. It says, play fair. It says, don't hit. Don't take something that doesn't belong to you. Say you're sorry if you hurt someone. But be prepared to share. Live a life that is full of some song and some dance and some learning and some work and some playing every day. Live a life of wonder. So we live a life of amazing wonder. As a kid, you will remember, everybody remembers, you were given a styrofoam cup in grade school or maybe preschool that had a little bit of dirt in it, and you got your hands sort of muddy and grubby, and your teacher then gave you a little seed, and you put the seed in the bottom, and then you left it. And then suddenly, roots would grow out of the bottom, and leaves and flowers would grow out of the top. And you couldn't explain it. Nobody knew anything about it except it happened. And wonder about that. And then the next thing was that he talked about was that in the Dick and Jane books, the very first and most important word was to look. When you go out into traffic, look, hold hands, watch for traffic. When you go out in the world, look and wonder. And do all of those things and listen. And explore everything that you find. Because it's all new. And it's all wondrous. And we don't have all the answers. And each day then just gets better as we listen to more stories from people who have diseases. Not diseases, but people who have diseases. And then we learn about them. And then we learn with them on how to approach those things that they have, that they carry with them. Happens to be a disease. Some of the time, they try to make sure that they don't continue to carry it with them. And some of the time, you say, how are we going to manage whatever it is? And so the whole thing, I think, the most important things that we give are the perspective of lives well led in the service of people that we interact with to make a difference.
Well, that's very profound, and I think our audience will really like that. Most people are aware of your many professional accomplishments, your publications. I'm going to speculate that you have close to 1,000 publications and book chapters, maybe more.
I don't have a clue.
But tell us a little bit about what you do for meaning and fun outside of work on a daily basis, or on a weekly basis. What does David Holmes do to recharge and enjoy life?
I think there are several things. I do play the piano. I'm not sure I would really denigrate the term play with what I do, but I enjoy that. I enjoy poetry. I enjoy that a lot, actually. I enjoy reading different kind of books, not just medical books, although they're incredibly wonderful, but books about terribly important issues, like the sixth extinction. All those sort of things. And then the family is at the center of all that. Because without the family, you sort of wander. So I am then really firmly held in place, not as a rock, but it is a place from which I can go out and back to which I can always go.
Yes. I remember distinctly some time ago we were discussing the upcoming ESC, European Society of Cardiology, and I said, "Are you coming this year?" And you said, no, I have to take my daughter to college. That's far more important, and I know you would do the same." And I was struck about how one of the leading interventionalists, academic interventionalists in the world, was saying, I'm going to miss this meeting because I have a higher priority. And I think that's a great example you've set for all of us over these years.
So I think those are incredibly important things to sketch out in your life going forward, those things which are crucial. There will be a lot of things that are fun. There will be things that are crucial. And we need to show up for those and have a presence there.
Well, that's very good, very profound. When you look back at the your time, you started cardiology as an EP physician and a cath lab physician, as I recall, and then you decided to focus in the cath lab. And you were one of the early pioneers with percutaneous revascularization. You were there from the first days, I believe.
Correct.
When you look back now from, let's say, the early 1980s until 2020, did you ever dream that we would be where we are today, that percutaneous revascularization is not only useful, but the preferred method of revascularization?
I think that what we always need to do when new technology comes along is to envision what the world in the future could look like based upon that. And when you approach it like that, then you can say, gosh, looking at this, I can only imagine in 10 years' time what it would be like if indeed you were able to accomplish things in the laboratory that in the past you had to only accomplish in the surgical suite. So an incredible sort of part of this in the current era is to say, we know that the mammary artery is an endocrine organ. We don't think of it like that, but it's an endocrine organ. We know that however God fashioned it, He fashioned it really well. He was doing okay with that. And we now know that there is work being done here as well as elsewhere that then would replicate a mammary artery and be able to have it on the shelf in the operating room. So when those patients come to surgery that need to have coronary bypass graft surgery, and there still are lots of patients that need to have that the surgeon then can say, I'll take that mammary on the shelf. And vein grafts then go away, and you'll leave your veins in your legs where they're supposed to be. And you'll then be able to revascularize everybody going to surgery with a mammary.
And with the endothelial function that it offers.
So I think those are the sort of things that you identify them early on, like when at the Grunzig meeting back in 1977, you would look at that and say, gosh, look at what might that be? The very first case was a person that had worked as a sawyer, and he then came in. He had a diagnostic angiogram perhaps a couple of weeks before that showed a patent LED, and when he got to the demonstration course, it was occluded. Grunzig just said, well, we might just as well go ahead and dye it. And that was the first chronic total occlusion that was done. So you look at that and say, gosh, look forward. It's a miracle. It's a wondrous thing. How then could it be translated into taking care of all the other patients that we will see? Because although we're incredibly keen to have it accomplished, we don't typically outgrow coronary disease.
You predict it's with us for at least another 50 years.
I think so. One could only hope that that won't be the case.
Yes.
So when I went to medical school, at that point in time, there were 3 people in the country. One happened to be the dean of the place where I went to medical school, all of whom were absolute world-class experts in tuberculosis. At that point in time, there were hospitals for patients with tuberculosis. They then were living and working in an environment that they were going to then work themselves out of a job.
They did.
And they did.
Largely in this country. Yes.
Largely in this country. But it would be the hope, it should be the hope for all of us, that we then bring along such amazing technology that indeed atherosclerosis becomes a thing of the past. It seems unlikely given the fact that it was there before the Egyptians built pyramids.
Yes.
So we've had it for a long time. But if we could then outgrow it or at least mitigate it until it happens much later, it'd be a terrific thing. We can only hope that'll be the case.
I guess it's conceivable that in 50 years' time, a great-grandchild or great-great-grandchild of yours will come into the Mayo Clinic and be a house staff officer, and someone will say, didn't your great-great-great-grandfather work here? Yes, what did he do? He was an interventional cardiologist. What's that? Oh, he treated coronary disease. Huh? They had a lot of it then? That would be a dream, wouldn't it?
That's a dream.
Yes, yes. When was the turning point in interventional cardiology that made it incredibly safe and durable? Was it drug-eluting stents or was it bare metal stents? Because I recall working with you in the cath lab and others, we would sometimes do a PTCA and the artery might decide to close down, and then we were 30 minutes with a perfusion catheter standing. I think it's good to say those days are over and that you're largely not needing to do that anymore.
I think that is correct. So as we think about the transformational technology that percutaneous revascularization has brought to bear in the field, there have been waves of that. Some of the time, the next wave dealt with patients that had unmet clinical needs. So for example, chronic total occlusion or diffuse disease. Another wave would have been to deal with the situation that you mentioned, that you brought some patient in, and for some reason or other, they were worse going out than when they had come in. And so then along with that, then stents were brought along. And then along with that, those stents that were meant to make everything perfect forever didn't last. And so we then had to say there are other issues. And so in the next wave of transformational technology was to say, let us treat those new problems that we never had before, because we weren't doing those things that caused those new problems. And the next wave after that is to say, how about diseases that we could never treat before? Let us identify for strategies of that. And then when we have done that, then maybe the tree of transformational technology that came out of the Grunzig and the early experience, maybe that tree now has multiple branches. So for example, we're able to dilate things in the gut. We're able to treat appendicitis with catheters. we're able to treat all sorts of nasal things with balloons.
And cerebral vascular
And
disease.
cerebrovascular disease. And so we now have technology for stroke that has a dramatic impact on patients' lives. If you were to say stroke is one of the most catastrophic things that could happen to a patient, we now have patients in whom we can bring them into the laboratory, whether that be a neurovascular laboratory or catheterization laboratory or whatever, and we can then take the clot out, and then at that point in time in selected patients, some of them sit up tall and rise from the dead. It's a manner of speaking, sort of.
Yeah.
There was an interesting case here. There was a physician who brought his wife in, and she had had a huge stroke and was obtunded. Was found to be suitable for this amazing technology. Was taken to the neurovascular laboratory here. Was seen within about 45 minutes of the onset of this, and they then aspirated the clot out of the middle cerebral artery, and the patient awakened. The physician, who was the patient's husband, went in and embraced the neurovascular interventionist and said, "You've given me back my wife." Wow.
What an amazing story, yeah.
And so we take technology that we can do and we apply it in places where we can do it, and we then give somebody back their spouse. And that makes the day.
That's something. I've watched you and our colleagues in our cath lab take many patients with acute myocardial infarction who are writhing in pain. And you can always tell when the artery is open because their heart rate and vital signs improve. They feel much better. And they tell me the pain went away within a minute of the opening of the artery. That has to give enormous satisfaction.
At the end of the day, that's the day really well spent.
Yes.
Now, there are other days that aren't all like that, and those are days that we learn from.
I think that's an important lesson, that just like with every year we have sunny days and snowy days and rainy days, life and work are sort of the same, aren't they?
They're going to happen.
Yes.
And so then, in those cases, it's incredibly important for team-based care to gather and say, this didn't work out. Did it work out because it wasn't meant to work out? Did it work out because we hadn't thought enough ahead about things? Or it was a case of lightning striking and we don't have anything that we can do about that? But those sort of learning experiences are terribly important for the career.
Do you journal or keep a record at all to remind yourself of these learning experiences? With your interest in literature and poetry, you obviously like to read, but do you keep any of this written down, or do you just catalog it in your mind and remember it?
I think, so this came up the other night. I was chatting with a colleague about another colleague, and we wondered how that other colleague was doing. And then I said, I can remember, and this must have been 25 years ago, that colleague's specific right coronary artery. And I could pick it out of a cast of 1,000.
If I gave you 10 angiograms, you could show me which one it is.
That was his.
Almost as unique as the fingerprint, huh?
Mm-hmm.
Yes. So you have essentially a photographic memory for some things.
For something.
I think
my wife would say, not a lot of things.
Yes. Well, I use a quote of yours often. I remind people that I have a really good memory, but it's short.
Right. That is true.
And so a lot of your aphorisms, many of us have borrowed and used widely. You've always been one who liked to solve problems. And you don't like the status quo. You think we should improve and restore health and improve life for our patients. So you've also been an inventor. And I don't know how many things you've invented, but the current Watchman device was an idea that you and others, maybe you alone, but I was thinking you and someone else, put together, and eventually Mayo Clinic sold it to a company. Is that right?
So it was on a napkin. up in the hotel just across from the Minneapolis airport, so there were 3 of us, 2 from here and 2 from Abbott, and at that point in time it was initially 3 and then became 4, and we had been chatting about things, and all of a sudden then on the napkin, having, I don't know, it could have been a beer, I don't know, maybe it was just coffee.
Inspiration hit at least.
The sketch of something came out. I wish that I had kept that sketch that I'd made, but out of that napkin then came Watchman. We had a wonderful experience, and it's been a team effort. So recently, this last fall, there was a celebration of sorts. The very first Watchman in the United States was put in on the night before Halloween in 2002 by myself and actually Doug Packer, and it was on Tom Munger's patient.
So for our audience, those are 2 additional Mayo cardiologists who are quite prominent in the world of heart rhythm.
And then
so you're going back to heart rhythm roots, it sounds like.
This last May, then Mayo then put in the 100,000th Watchman globally.
18 years, well less than 18, 17 years and 7 months or 6 months later from Watchman number 1, you put in Watchman 100,000.
Mayo did. I was out of town.
Mayo did.
So the nice thing about that is that you have kids and you grow them up, and they're then much better than you are. Wow. Is that great or what?
You have certainly trained several generations of interventional cardiologists. And to see you at national meetings or international meetings, they all come back to talk to you. You have to feel a sense of pride and joy at watching all of these kids sort of grow up to become good cardiologists.
It is the best. I will tell you one other piece of information about growing up kids. I was at TCT, one of the real important meetings. It was a few years ago. And I had given a talk. My son had also given a talk in bioengineering. We then were on a bus to get to the airport because it was going to be out at Dulles. And so, as I stood there, hanging to the on the thing that keeps you from falling, somebody came over, and said it was just terrific. And then I was getting ready to say, well, thank you very much. And it turned out he then went right on by me and to talk to my son. And then my son then introduced me to this man that had just congratulated my son on his talk.
That's wonderful.
I thought, wow.
That's amazing.
It's the best ever.
That is the best. Yeah, your son chose biomedical engineering instead of medicine. Was that tough on you at all to see him go that path, or were you delighted for him?
Delighted.
And he's been quite successful here doing that. What about your daughter? I remember she's the one who was off to college when we were talking. What is she doing now?
She works in Denver with the Society for Performing Arts.
Oh, wonderful.
So she's in development, and they're putting on things like Rent and Lion King at the Denver Opera House, or at that performing center. So that's what she does.
Sounds like she has your drive as well as your wife's organizational skills.
It's a good thing that she has my wife's organizational skills, because they're lacking in me.
Oh, you're a visionary. It's sometimes hard for visionaries to plot out exactly how to go from point A to Z, because there are 20 some odd steps in between. But I think you've always been inspirational to many of us, because Wayne Gretzky once said, you don't skate to where the puck is, you skate to where it's going to be. And David, I think you're a couple of links ahead of where that puck is going to be, so they can pass it to you and you score. You've always had that ability to see, and I think I'm guessing that your reading of poetry and literature has given you insight into how things go that many of us may not have. Let's switch, if we can, and get to the last big breakthrough that I think that you've been a major part in, and that is changing how we do aortic valve replacement. I work every day, it seems, in our valve clinic, and I have yet to have a patient say to me, "Doctor, I prefer open heart surgery. I would like the new Tavor valve." And of course, we're trying to figure out who the Tavor procedure is most appropriate for and who surgical replacement is most appropriate for. But if you could describe in just a sentence or two the transformation of aortic valve replacement using Tavor, what are your thoughts?
I think it is indeed transformational. I think when it first came out, would have been at the time that myself and then Michael Mack, a surgeon, we were the respective presidents of our societies. So we were then at the table with FDA, trying to then decide about what FDA was going to do about approval, and following approval, how then were you going to put it out to the country, because it was good for treating unmet clinical needs. And so the whole story of Tavor has been that journey from taking incredibly interesting technology to a group of patients that didn't have any other option, to now moving through to those patients that could have surgical aortic valve replacement, or now Tavor, to those patients who couldn't have surgical aortic valve replacement that can have Tavor. And so it's been an amazingly good journey. I think that part of these journeys is we talked about how new technology could impact on the future. We need to remember to say that there is a future for these technologies that we think solves everything now, that in 10 years, not going to be sure.
Sure.
And so the longitudinal follow-up of these patients will be incredibly important, because you're exactly right. Nobody wants to have surgery if they could be treated equivalently in another way.
Sure, sure. And I must say, to see patients leave hospital 1 or 2 days after a procedure, go back
Terrific.
to work. I've had cases where farmers get Tavor in early October. The next week they're harvesting their crops. For them, that's their life income. They need it.
Terrific.
Yes. Do you foresee the day that Tavor will maybe be expanded to aortic regurgitation or bicuspid aortic valves? I know it's being done off-label, but it's not generally in the label yet. Will that happen at some
I
point?
think we'll need continued technology advancements, number one. Number two, we need to realize that at the present time, Tavor is typically used in patients that are greater than, say, 65 or 70. As we move towards bicuspid disease and some aortic regurgitation patients, they're much younger. Now that has the issue that that prosthesis that you put in has to now last 30 or 40 years. We don't have 30 or 40 years of data. Now, in those patients that get a bioprosthetic Tavor valve at the age of 75 or 80, you can treat them again with another one when they're 90. But there aren't all that many people that come back at the age of 110 that need to have another valve. However, if you have that first valve at the age of 45, to have the next one at 55, the next one at 65, the next one at 75, pretty soon you run out of real estate.
That's right.
And so that's a terribly important part of the regulatory space and the professional societal space that we, as you and I, as other people in the field, have to say, we need to continue to look for better approaches, number one. We need to continue to document that in 10 years' time, things are as good as they look like they are.
And maybe someday we can have a percutaneous mechanical valve.
That'd be terrific.
Would be.
There's technology in South Africa now
Doing that?
that's a valve that, number one, the leaflets don't wear out. Number two, they don't clot. Number three, they can be put in transapically, like a Tubbs dilator used to be done. Now that may be the future.
That may be. Well, listen, I really appreciate your time today. Our audience appreciates the chance to hear your story and to learn more about you. I would like to ask you in 5 or 10 years' time to come back and share more about this exciting career and journey that you have been on and will continue on with interventional cardiology and perhaps other spaces of cardiology as well. Is there any final words you'd like to have for our audience today about medicine and life in general?
I think to look and wonder and dream. Whew. Damn.
Thanks much.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.